We start the next session immediately, and the first speaker is Professor Mitani, our chairperson, and you'll talk about Darbepoetin. Please.
Thank you for your kind introduction, Emma. First of all, I would like to express sincere appreciation to both the Congress President to inviting me here in this early spring. Thank you very much. This is my COI. Darbepoetin alpha is a re-engineered form of erythropoietin containing 5 amino acid changes, resulting in the creation of 2 new sites for N-linked carbohydrate addition. And by this structural change, Darbepoetin alpha has acquired a 3-fold longer serum half-life compared to epoetin alpha and beta, and is administered with a longer dose interval. Here in Japan, we administer Darbepoetin alpha once a week subcutaneously. This slide shows a therapy algorithm in MDS published by the Japanese Society of Hematology last year. We also divide MDS patients into low and high risk categories. Please look at the algorithm for low-risk patient. If patients do not have any clinical symptom, we wait and watch. If patient has some clinical symptom, there are several options for the treatment. Especially for the treatment on anemia, we can choose a transfusion with iron chelation therapy and cytokine therapy such as Darbepoetin alpha. Recently, we used Darbepoetin alpha before patients becoming transfusion dependent. Anabolic steroid is another option for the treatment of anemia, but is not approved in Japan. Immunosuppressive therapy, IST, is applicable for borderline patients between aplastic anemia and MDS, and it's sometimes useful in special cases. Dr. Hosokawa will talk about this issue later. Lenalidomide is chosen for 5Q- patients, of course, but those patients may account for only 5% in Japan. The therapy with azacitidine is selected carefully for special cases because immunosuppression is a serious problem in this therapy. Here I would like to introduce a clinical study, the result of which became a basis of the approval of Darbepoetin alpha for the treatment on anemia in MDS. This trial was a multi-center randomized open-label phase 2 comparative study conducted in Japan and Korea. Patients were randomized via a dynamic allocation method and were assigned to each Darbepoetin alpha cohort, namely 60, 120, and 240 microgram, in a 1:1 ratio after stratification by ethnic groups, Japanese or Korean, and serum EPO levels less than 100 or equal and more than 100 international unit per milliliter. Darbepoetin alpha with the corresponding dose was given once a week until week 16, and then a dose escalation and change of dose frequency were allowed depending on the response during the treatment period from week 16 to 32. That was end of the study. The primary endpoint of this study is the rate of minor and major responses. Definition of minor and major response are described here. A minor response requires more than 50% of decrease in RBC transfusion volume from the baseline for consecutive 56 days, while major response requires RBC transfusion independence for more than consecutive 56 days and more than 1.0 gram per deciliter increase of hemoglobin level from the baseline. Unfortunately, there was no statistical difference among three dose groups in terms of response. However, more major responders are observed in 240 microgram group than 60 or 120 microgram group. Based on this result, Japanese government approved 240 microgram of darbepoetin alpha treatment on anemia in MDS. This slide shows epidemiological survey on low-risk MDS in Japan conducted by the Japanese National Research Group on idiopathic bone marrow failure syndromes. Median age was 76 years old. Mean ratio was 61%. And in IPSS, low and interval patient accounted for about 40% and 59%, while in IPSSR, very low intermediate patient accounted for about 17%, 50%, 28%. Regarding transfusion dependency, RBC transfusion-dependent patient accounted for 19%, and platelet transfusion-dependent patient 4.4%. In Japan, patients with more than 50% of ring sideroblast in the bone marrow accounted for only 10%, and patients with more than 200 of serum EPO level, 1/3. This slide shows therapy selection at diagnosis. Regarding ESA therapy, about 26% of transfusion-dependent patients were treated with darbepoetin alpha, while about 11% of transfusion-independent patients were. 36% of transfusion-dependent patients received transfusion only. We now know several determinants for ESA responsiveness. Regardless to say, low EPO levels and low transfusion burdens are the strongest indicator for ESA responsiveness, which has been demonstrated by Eva herself. Besides those, low serum ferritin, low in IPSSR, activated STAT5, absence of aberrant flow markers such as CD7, and low mutation gene number are described as an indicator. To analyze gene mutations that predict response to darbepoetin alpha in lower risk MDS patient, we conducted MDS-01 trial in West Japan hematology study groups. We have already published this paper, but I would like to introduce the study here. Eligible patients are those with lower risk MDS, namely low or INT1 according to IPSS, and darbepoetin alpha at a dose of 240 microgram was administered once weekly for 40 weeks, 16 weeks. Peripheral blood sample of the subject was collected before administration of darbepoetin alpha, and extracted genomic DNAs were then analyzed for gene mutations with a panel of 376 genes. Analysis was performed to confirm whether the presence of a specific gene mutation with a frequency of equal and more than 10% affects the efficacy of darbepoetin alpha. Primary endpoint was a correlation between highly frequent, namely equal or more than 10% gene mutations and hematological improvement erythroid, according to the IWG criteria 2006 at week 16 after the initiation of the darbepoetin treatment. We also recorded all adverse events. A total of 85 patients underwent enrollment screening. Of these, 79 subjects were included in the full analysis set. after excluding for ineligible patient and to patients who withdrew their consent before the start of protocol treatment. This slide shows baseline characteristics of the subject. Median age was 77%, and male ratio was 66%. The median hemoglobin level was 8.1 gram per deciliter, with 7.8 in the transfusion-dependent cases and 8.1 in transfusion-independent cases. Patient distribution according to the fourth edition and the revised fourth edition of WHO classification in IPSS, IPSSR is described here. Tendencies were almost similar to those in the epidemiological survey that I just introduced before. However, more than 15% of patients with increased winged sideroblast and or SF3B1 mutations are observed in this study. 90% of the patients were transfusion dependent, and about 50% of patients shows equal or more than 100 of serum erythropoietin level. This slide shows rate of overall response to darbepoetin alpha at week 16. According to IWG criteria, 71% of patients achieved HIE, with 73% in transfusion-independent cases and 60% in transfusion-dependent cases. Major and minor responses were observed 47% and 60% of transfusion-dependent cases. The treatment with darbepoetin alpha appeared more effective in transfusion-independent patients than transfusion-dependent patients. This slide shows EPO levels before the darbepoetin alpha treatment in the non-responders and responders. The B-swarm box plot analysis of EPO levels in non-responders and responders indicated a statistical difference between them. The median EPO levels was 358 in non-responders, while 66.3 in responders. We confirmed that EPO level is a strong indicator for success of darbepoetin alpha treatment. This slide shows a landscape of genetic alteration in the 83 cases, including gene mutations and copy number aberrations. And FAB and WHO classification, IPSS, IPSSR, and karyotype risk are described here. This analysis was conducted by Dr. Ogawa and Dr. Nanya. The highly frequent gene mutations included those in the SF3B1 gene at a frequency of 30%, TET2 gene 25%, SRSF2 13%, SXL1 gene 11%, and DNMT3A 10%. As previously reported, RNA splicing and epigenetics regulated genes were a major target for the mutation in our cohort. This slide shows an association between gene mutation and response to darbepoetin alpha at week 16. We analyzed a relationship between highly frequent gene mutations and rate of hematological improvement by univariate analysis. But this analysis failed to show any correlation between these mutations and efficacy of darbepoetin alpha. The same results were obtained when the analysis was limited to transfusion-independent patients. This slide shows the result of multivariable analysis, including baseline EPO and baseline transfusion volumes as variables. As a result, ASXL1 mutation and baseline EPO levels were identified to independently predict a poor response to darbepoetin alpha. Baseline transfusion was not detected as a predictor, possibly because a major part of our cohort were transfusion independent. This slide shows a responsive rate to darbepoetin alpha in the subgroup classified by baseline EPO levels and the presence or absence of ASXL1 mutations. The responsive rate in subject with lower EPO levels with ASXL1 mutations minus and plus with higher EPO levels with ASXL1 mutation minus plus were 89%, 80%, 60%, and 0%. These data indicate even if patients with higher EPO level, they may respond to darbepoetin alpha therapy if they don't carry ASXL1 mutation. This slide shows progression-free survival to AML and overall survival on 58 subjects who continued treatment without progression to AML till week 16. Progression-free survival at year 1 was 81.7, with median survival time being 38 months, while overall survival at year 1 was 83.5%, with median survival time being not reached. This is discussion and summary at that time. This prospective study provided the first evidence in the ESA therapy that the existence of some specific gene mutations, namely ASXL1 mutations in this case, may be associated with response to darbepoetin alpha. When patients have both the predictive factors of poor response, namely higher levels of EPO and ASXL1 mutations, alternative therapies would be recommended as the first-line therapy for anemia, such as Luspatercept. Even in cytokine and other types of therapies for anemia, molecular stratification need to be established to determine their application precisely. Thank you for your attention.
Thank you very much. Very, very interesting data. I think we have to obey now the chairs of this symposium and take the questions later. So I think the next thing is a banded, recorded talk by Professor Uwe Platzbecker. Do you have it up and running now, or should we have a question in between? Could you just make a sign if you have that, if you have the Dr. Platzbecker's recording?
So, hello everybody. Yeah. My name is Uwe Platzbecker from the University Hospital Leipzig in Germany. And again, it's a great pleasure and honor to being invited to this symposium and to talk about Luspatercept as a novel treatment opportunity for patients with low-risk MDS. These are my disclosures. So I will start actually with a very, let's say, simple slide. This is the IPSSR, which is still, I would say, the backbone for the categorization and prognostication of patients with MDS. And traditionally, actually, patients with very low, but also a large group of intermediate risk patients are considered to be lower risk. And for these patients, a limited number of therapeutic options are available. But I think Luspatercept is one of the recent advances, which I will actually touch base in the next couple of minutes. I also emphasize the IPSSR at the very beginning because we have a recent development, the IPSSM, which also now includes molecular abnormalities being prognostic in the given patient population. And this is important because morphology is informative, but is actually not prognostic in many cases, and especially if you have patients with ring sideroblastic phenotype, SF3B1 mutation actually matters with regards to the survival, but also the cumulative incidence of disease progression. So patients with a ring sideroblastic phenotype and an SF3B1 mutation actually have a very good prognosis. And this has been introduced into the recent WHO classification now with the new category of MDS SF3B1 patients with less than 5% bone marrow blasts and an SF3B1 mutation. And I think, therefore, not only morphology is very important for the workup, so the ring sideroblastic status is still very important also for the Luspatercept label, but I think SF3B1 confirms the very good prognosis of these subsets of patients where I think transplant is not needed in the majority of the cases, and Luspatercept is a very important treatment option. And this is actually about low-risk MDS and therapy. I will not talk about thrombocytopenia, not about del(5q) MDS, but will predominantly focus on patients with anemia and non-del(5q) disease, where EPO or ESA is actually still considered first-line therapy for the majority of the cases, and stratification, of course, is made by the EPO endogenous EPO level. This is again data from the pivotal phase 3 trial, and the response rates actually are less than 50%, and in this trial actually patients with an EPO level of less than 200 were the only ones responding. So still, I think EPO or ESA therapy is the mainstay, and then patients failing or not being eligible to it, we currently consider the ring sideroblastic phenotype / SF3B1 mutation as an entry for considering Luspatercept as a second-line therapy based on clinical trial data, which I will introduce to you in the next couple of minutes. The development of Luspatercept actually was based on the better understanding of the pathophysiology of MDS and also the close interaction of mesenchymal stromal cells on one side, but also the hematopoietic stem and progenitor cells on the other side. And this, let's say, disturbed microenvironment is actually driven by plenty of factors, and some of them are actually not discovered. But there was evidence that also markers of inflammation and also the TGF-beta pathway may be involved into ineffective hematopoiesis. So GDF11 was, at least in a mouse model, shown to be important, and the interference with GDF11 or GDF8 actually led to an improvement of anemia and in this mouse model, and was then the backbone and the rationale to develop Luspatercept, but also Sotatercept at the same time for patients with low-risk MDS. I will not touch base here on Sotatercept because this was then later developed in pulmonary hypertension, but Luspatercept as a GDF8 and GDF11 ligand trap was chosen to be developed clinically in lower-risk MDS patients. And I think the rationale also for phase 3 trials was based on the PACE study, phase 1/2 trial, open label dose escalation study, where actually Luspatercept was titrated from a very low dose up to the dose we currently use as a maximum dose, 1.75 mg per kg. And a whole very heterogeneous group of patients with low-risk MDS received Luspatercept, including non-transfusion dependent, transfusion dependent, ring sideroblastic, non-ring sideroblastic. And this is one of the first, I would say, index patients which we reported at the ASH 2014, a patient with MDS, RS, MLD, failure to LEN and EPO, transfusion dependent, and you see the patient achieved a steep increase of hemoglobin levels and then continued to be transfusion independent. So this, I think, was one of the first patients where we started to believe that this drug may be a game changer in low-risk MDS patients. So the further development then included more patients, all with different endogenous EPO levels, but also came out pretty fast that ring sideroblasts turned out to be a biomarker for a better response, as you can see here in this table. And this actually was confirmed then with the first publication, 69 versus 43%, again at the initial report, and only a small number of patients being RS negative. And this PACE trial then was the fundament for the medalist study in ring sideroblastic patients only failing ESA-based therapy, which was the phase 3 trial, and finally led to the approval of Luspatercept in the given indication. Again, as a reminder, this is the primary endpoint of the medalist trial. Also, multiple responses were actually were observed, and the responses actually were observed regardless of the SF3B1 allelic burden and also the total number of baseline mutations. With a longer follow-up of this trial, you can see that predominantly patients with low transfusion burden actually responded. You see also high transfusion patients can achieve transfusion independence, but the majority actually achieve a reduction of the transfusion burden. About side effects, I think the drug is very well tolerated, but fatigue, asthenia is or can be observed, is mostly mild in these patients, but some of these patients actually require drug holidays or a sometimes a dose reduction. I already mentioned the multiple responses, and this is actually shown here. So some patients with a long transfusion-free interval, then receiving another transfusion, then achieving a subsequent and consecutive interval transfusion independence. And this is just highlighted here in a very simple manner. You see, I think what we basically want to achieve is transfusion independence and the concomitant increase of hemoglobin levels. But also some patients achieve transfusion independence, but then have a single transfusion event and then should be also continued on luspatercept. And then other patients just achieve a reduction of the transfusion burden, in this case here by at least 50%, which I would also consider a clinical benefit in these patients. Especially in patients with high transfusion burden, dose escalation is mandatory up to 1.75 mg per kg. This is again taken from the medalist trial where actually it could be shown that especially these high transfusion burden patients required dose escalation in order to achieve a significant response. With a longer follow-up of the PACE trial, also patients, and now you see that compared to the initial report, more than 100 patients were included. Also patients with low transfusion burden or even ND, non-transfusion dependent patients were included. And you see that the response rate here is actually 90% compared to 50, almost 50% in the non-RS patients. So it's being suggestive that the earlier you treat these patients, the better is the response, especially in the ring sideroblastic phenotype. But what also I think was interesting observation is that the drug maybe by modulating the osteohematopoietic niche also induces an increase of neutrophils, as here again from the medalist trial, and also of platelet counts. Again, the majority of these patients had actually normal neutrophil and platelet counts, but I think it is interesting observation and suggesting that the drug may modulate the osteohematopoietic niche in a more holistic way. With a longer follow-up also of the medalist, you see that roughly 50% of the patients responded, and patients with a response and a concomitant increase also of hemoglobin levels had a better survival compared to patients actually not achieving a response. So compared to the Medalist trial, the COMMAND study was different with regards to the design. So patients with, again, lower risk MDS, according to the IPSSR, with an endogenous EPO level of less than 500, but being treatment naive to EPO or ESA, were randomized to EPO versus luspatercept. Again, with the intention to show that luspatercept is superior to EPO alpha. Both patients, ring sideroblastic positive and negative, actually could be included, and the primary endpoint was actually a 12-week transfusion independence with a concomitant increase of the hemoglobin level. So this is the patient disposition, and you see again that predominantly 70% of the patients had a ring sideroblastic phenotype. All of them, of course, were transfusion dependent. And this is what the primary endpoint actually was achieved. There was a significant difference for luspatercept compared to EPO alpha. So significant more patients achieved transfusion independence. Also here for 24 weeks, and this is according to the HIE. So the study actually met its primary endpoint and was positive. This, let's say, significant difference was very, very much achieved, especially in the ring sideroblastic patients, whereas in the ring sideroblastic negative patients, response rate were comparable. Also, response rate were significantly different in patients according to the EPO level, less than 200 and 200 to 500. What about durability of response? You see that there was a significant difference in favor of luspatercept, so significant longer durability. This was here for the entire population, now for ring sideroblastic positive patients, and last but not least for RS negative patients. Again, small numbers, but I think pretty much in line with the previous slides. So what about biomarkers of response? I think an interesting observation from this trial was that in the EPO alpha arm, actually patients being non-responders had a significant higher number of mutations like TET2, DNMT3A, SF3B1, or the mutation panel was actually performed in this trial. And the same was not the case for luspatercept. So luspatercept worked irrespective of the number of mutations. Currently, it is believed that luspatercept is predominantly trapping GDF8, GDF11, and by doing so, it is inhibiting. It's taking away the inhibition of the maturation, differentiation of erythropoiesis in the bone marrow, and by doing so, improving the ineffective hematopoiesis in the bone marrow. But it's actually also interesting to speculate that also other cell types, especially stromal cells, may be also affected by this. And an interesting observation also from the COMMANDS trial is that in contrast to the EPO alpha arm, luspatercept actually led to a kind of depletion of GDF11 plasma levels, as you can see here. So again, showing that the drug hits the target and is also a differentiating agent compared to stimulation by EPO alpha. And last but not least, this is a study we published a couple of years ago showing that luspatercept also modulates the mesenchymal stromal cells and via inhibition of GDF11, and the mechanism, at least the one we could provide evidence for, is that that luspatercept actually increases stroma-derived STF1 levels, which may in turn then improve the differentiation, maturation also of early progenitor cells. And this was also confirmed by STF1 level assessment in the bone marrow of responders versus non-responders. So to make, let's say, a long story short, I think that within the last 10 years, luspatercept, I think, has significantly changed the therapeutic landscape in lower risk MDS patients. I think it's a major step forward and was approved based on the Medalist trial, and also achieved another important milestone by the recent FDA approval as a first-line therapy for all comers, low-risk MDS patients being red blood cell transfusion dependent, irrespective of the ring sideroblastic status. This decision is actually still pending for the EMA, but I think what we can definitely say at this stage is that the Luspatercept actually is a very important drug in the armamentarium for low-risk MDS patients. Still, we need more studies, and we also need now, I think, as a next step, combination trials to potentially rescue those patients not responding or subsequently losing the response. With that, I would like to thank you for the attention. I'm happy to take questions.
Okay, to my information, Dr. Platzbecker will not attend the Q&A session, so we have to email him questions. There are many important and interesting aspects of this interesting talk. So in the interest of time, we will now conclude with the last talk of the day. Dr. Hosokawa will give a talk on immunosuppressive therapy. So welcome. And then we will have a short Q&A session.
Thank you for kind introduction, and I'm very happy to be here today. And I'd like to thank Professor Ogawa and Miyazaki for giving me this great opportunity. So today I'd like to talk about the immunosuppressive therapy for MDS. So I have two topics today. Then one is the immunosuppressive therapy for MDS. So first, I'd like to make some brief review. And I'd like to think about which subset of MDS patients actually have the benefit from IST. And the second topic is a diagnosis of the immune pathophysiology in patients with bone marrow failure. So we all know that the immune cell dysfunction, such as the MDSCs or Treg or CTL or NK cells, are important, and also the aberrant cytokine production and stromal cell destruction are the three core aspects of immune microenvironment dysfunction, and also this is central to the development and progression to MDS. We also know that the immunosuppressive therapy is reported to improve the cytopenia in some patients with MDS. So if you go back to the literatures, there is some reports from the US, in Europe, or from Japan, and that immunosuppressive therapy effective in some patients with MDS. However, the most study of IST in MDS are limited by the small number of patients and their single-center nature, and thereby report a conflicting result. And also the heterogeneity of the MDS itself, and several treatment options make some difficult, complex. So if you look at the large multi-center international cohort study from the Europe and the US, 207 patients with MDS received IST, and overall response rate is about 50%. And the transfusion independence was achieved in about 1/3 of the patient. And the hypocellular bone marrow and the use of host ATG plus cyclosporine are associated with the increased rate of the transfusion independence. In this study, they tried to identify some clinical or molecular predictor of response. However, they failed to identify any predictors. Then when we look at the achievement of transfusion independence, then they found that the use of host ATG and the hypocellular bone marrow is the predictor of the response. And this is another systematic review and meta-analysis studying the effect of the IST for the lower risk MDS patient. And there are 9 prospective cohort studies and 13 clinical trials with a total of the 507 patients. And the patients were treated with ATG and ATG plus cyclosporine, or ATG plus etanercept, or cyclosporine alone, or other IST regimens, such as other IST regimens. So if you see the overall response rate, it's demonstrated that overall response rate is about 42%, with a CR rate is about 12 to 5%. And the achievement of red blood cell transfusion independence is 1/3 of the patient. And then again, they are unable to validate any biomarkers to predict our response to IST. So we reviewed that the overall response rate is about 40 to 50%, and they got some transfusion independence in 1/3 of the patient. So the next question is, which subset of MDS patients actually benefit from the IST? So when we look at the updated NCCN guidelines updated this year, there is some management of the lower risk diseases. So if you see the cytopenias, and there is clinical relevance, thrombocytopenia or neutropenia, then we can choose the dasatinib or dasatinib, and also the immunosuppressive therapy. So immunosuppressive therapy is useful in certain circumstances. And then if you have some symptomatic anemia with no derivation 5q and other cytogenic abnormality with lymphocyte less than 50%, and if there is a serum EPO level is more than 500, then we have a chance to consider the use of the IST, ATG plus cyclosporine plus minus EPAC, if there is a good probability to respond to IST. So they said that the IST is recommended as an option that is useful in certain circumstances for selected patients. So what is the certain circumstances? So they summarize like young and low marroblast and hypocellular marrow, and the presence of the PNH clone and STAT3 mutant CTL clones are identified. So I will briefly summarize this result. So as you know, the plastic anemia and MDS and sometimes PNH or LGLs are overlap disorders. And if you see the hyperplastic bone marrow and some dysplasia, so we sometimes diagnose this as the hypocellular MDS. And sometimes it is very difficult to distinguish this disease, aplastic anemia and MDS. So as you see in this morning session, the hyperplastic MDS is recognized as a distinct disease type in a 5th WHO classification. As you can see here, the MDS hyperplastic is recognized as a morphologically defined disease type. And by definition, less than 25 bone marrow cellularity age-adjusted is defined. However, the emphasis is placed on a careful morphological evaluation, typically requiring the peripheral biopsy evaluation, in addition to the bone marrow smears, and detection of the mutation or the clonal cytogenic abnormality is also important. Then the positivity of the PNH clone is also important when we consider the IST for MDS patient. So this is a clinical and studies, retrospective study from the UK group looking for the clinical and prognostic significance of a small PNH clone in MDS and AA patient. So this pie chart shows the PNH clone size in a granular site, according to the diagnosis. So if you see the PNH clone size higher than 50%, and most of the cases was diagnosed as a PNH. And if you see the MDS, if you see here, the clone size of the PNH clone is usually very small size compared to the aplastic anemia and PNH. And the PNH positive MDS cases were significantly more often hypoplastic and mainly displayed IPSS low or into 1 score and deeper cytopenias, especially for hemoglobin and platelet, and higher LDH levels. So if you see the response rate in MDS and AA according to the PNH clone positivity, the patient with PNH clone had a higher response rate compared to the patient without PNH negative PNH clone negative patient. And also this is true for the aplastic anemia patient. The PNH positive patient have a higher response rate to the ISD. And if you see the overall survival at 8 years, and PNH positive patient tend to have the higher overall survival compared to the PNH clone negative patient. And also it is true in the aplastic anemia patient. So this data suggests that the presence of the PNH clone is associated with the immune pathophysiology, both in MDS and AA patient. And this is another prospective study performed in Japan, a prospective multi-center study in Japan. And peripheral blood samples of the more than 2,000 patients were assessed using the high sensitivity flow cytometry assay for detecting the PNH type cells. And PNH type cells were detected in about half of the aplastic anemia patient and 13 to 7% of the MDS patient. And when we look at the MDS subtype, interestingly, none of the 35 patients with refractory anemia with linked sideroblast or 86 patients with RA with excess blast had these PNH type cells. So this also suggests that the presence of this minor PNH clone are associated with the benign bone marrow failure and associated with the immune-mediated bone marrow destruction. So when we look at the response rate to the ISD in each subgroup, the response rate is tend to be higher in the PNH positive patient compared to the PNH negative patient. And when we look at this MDS diagnosis, then also PNH positive MDS patient had a higher response rate of ISD compared to the PNH negative patient. Also, we performed the clinical significance of the minor, which means around 0.01%, which sometimes we see in the clinic in bone marrow failure. So when we compared the two high sensitivity flow cytometry assays, and they found the PNH, they can detect the minor PNH clone on the same way. And we saw some similar sensitivity. Then this bone marrow variant with a minor PNH clone had some better overall survival, and they had 100% overall survivors who were treated with ISD, and they have a statistical significance. And interestingly, these PNH phenotype cells are detected in patients who received the CD90 targeted CAR T cell therapy. And this is a recent publication from another Japanese group. And we sometimes see the bone marrow failure after the CAR T cell therapy, which is clinically problematic. And when we perform the bone marrow biopsy, and we see many fatty bone marrow, and we check the PNH type cells by flow cytometry, and we could detect this minor PNH clone. So in this study, in 70 patients, and from the 70 patients, and the 10 patients had this kind of minor PNH clone by flow cytometry. So it's also so this data also suggests that the presence of minor PNH clone represents the some escape hematopoiesis from the immune cell attack. This is not the story of the PNH clone, but this is a typical cytogenetic abnormalities related to the immune pathophysiology in MDS. So we sometimes see the patient with deletion 13q, and we see that bone marrow, and there is almost no dysplasia, and most of the patient had hypocellular bone marrow. And we performed the PNH clone detection, and all 16 patients had PNH type cells by flow cytometry. And most of the patients received IST, and they got better responses. So all patients with deletion 13q alone responded to IST, and with 10 years overall survival rate is 83%, which is more comparable to the result of the aplastic anemia. Also, the PNH clones define the subset of define a benign subset of bone marrow failures in patients with trisomy 8. So if you see the overall survival or event-free survival of the patient with trisomy 8, then the patient with PNH clones had better overall survival than the patient without the PNH clones. And this is the result of the multiple varied analysis, and younger ages and the presence of PNH clone is a better, good prognostic marker in patients with bone marrow failure with trisomy 8. And the final one is the STAT3 muted CTA clone. So this is another point that when we consider IST for MDS. STAT3 mutation, if you can be found usually in the LGL, but sometimes it is found in not only in the LGL concomitant cases, but in a small proportion of unsuspected cases. So we can see this STAT3 muted clone in 7% of AA and 2.5% in an MDS patient without the evidence of LGL. And we compare the clinical characteristics between the MDS patients according to the STAT3 mutation status. The patient with the STAT3 mutation tend to have the lower white blood cell count or neutrophil count, and tend to have the hypocellular bone marrow. So the next question is, which subset of MDS patients do not benefit from IST? So when we go back to the previous study, then they failed to identify some predictor of response. But when we closely look at the result, the presence of SS3BR mutation tend to have the worst outcome after the immunosuppressive therapy. But however, it did not reach the statistical significance. But another group also retrospectively analyzed the predictor of the IST, and they also found that mutant SS3B1 mutations are associated with the negative factors associated with IST. So it is interesting to see that the PNH type cells are not detected in the RS in our cohort. So I think that these diseases they're not mediated by the immune cell destruction. The final question is, does IST itself have any effect of the clonal evolution to AML? So this is a bit old study, but they compared the mortality rates and the leukemic progression rate between the similar age-adjusted and disease-adjusted MDS patient, and the proportion of the ML tend to be lower in the patient treated with the IST. So it is likely that the IST itself does not have any effect to the effect for the coronary evolution to MDS patient. So for the rest of the time, I'd like to briefly introduce how we diagnose the immune pathophysiology in patients with bone marrow failure. So there are some laboratory tests for diagnosing the immune-mediated bone marrow failure. So sometimes mild to moderate dysplasia in myeloid cells or erythrocytes are common in immune-mediated bone marrow failure. So morphological assessment have some little prognostic value in the management of bone marrow failure without increased blast. And the pattern of cytopenia is also important, and the predominant decrease in the platelet count compared to that of the neutrophil or erythrocytes. And assessment of megakaryocellularity is also important, and decreased production of megakaryocyte is a characteristic unique to the immune-mediated bone marrow failure. So in the ITP patient, because of the hyper-megakaryocytes, the plasma TPO levels are usually low. And in aplastic anemia, due to the hypocellular megakaryocyte, and the plasma TPO levels are usually high. So how about the MDS? So when we check the many patients with MDS, and there were some patients with higher TPO levels in that some MDS patient, but the higher TPO levels were not detected in the patient with a LAI patient. So if we divide the patient, MDS patient with the high TPO levels and low TPO levels, and see the survival, and the TPO high patient tend to have the higher immune response rate to the immunosuppressive therapy, and also have the better overall survival. So we think that the microcystic plasma high TPO levels are associated with the immune pathophysiology. And also the coronary hematopoiesis is important, we recently performed the energy analysis, and the BCOR and PGA and DMT3A and XL1 is the top frequently mutated genes. And good response to IST was observed in the PGA mutation and the BCOR LR mutation in AA patient. So responsiveness to immunosuppressive therapy in patient was validated in the PGA and BCOR and BCOR mutation in aplastic anemia patient. So I think that this presence of the minor PNH clone is also important. And also the BCOR and BCOR-L1 is associated with immune pathophysiology. So this is a summary slide on the potentially useful markers for estimating the etiology of the bone marrow failure. So if you see the deletion 13q or PGA or BCOR mutation, or increased percentage of the PNH type cells, or increased plasma TPO levels, so we think that this is immune-mediated bone marrow failure. However, if you see the deletion 7q or DMT3 or XL1, and this status is a pre-leukemic status. So this is a summary of my talk today. IST is effective in some patients with MDS, and typically the young and less than 5% marrow blast, and those with the hypocellular marrows, and PNH clone positivity, and start cell mutant CTL clones benefit from the IST. And the presence of SF3 mutations may negatively predict for response to IST in MDS patients. And moderate to mild dysplasia in myeloid cells or erythrocytes are common, and the decreased production of megakaryocytes is characteristic to immune-mediated bone marrow failure. And identify these immune mechanisms using the laboratory markers such as the PNH clones are important in the management of the bone marrow failure, and help physicians to choose the appropriate therapy. So I'd like to acknowledge all the collaborators, and especially I'd like to thank the former Professor Nakao and Dr. Neil Yang at NIH, who given me this great insight in the field of bone marrow failure research. And that's all for today. And I thank you for your attention. And I'd like to take any question.
So thank you very much. I think we should be quite short, but we have time for some questions, and I would like to ask the first one. And I'm a bit surprised that the NCCN guidelines do not recommend that you do an NGS screen before you take the decision about IST. How do you do yourself? Don't you take a full ordinary NDS screen and check for germline mutations before you start IST treatment?
You said NGS analysis when we considered IST, right? Yeah.
No, I was asking, what do you do yourself? If you're evaluating a patient for IST, wouldn't it goes without saying that you check the mutational status with the targeted analysis?
We are not actually routinely doing the NGS analysis, but we usually do it for the research oriented. But retrospectively, we saw a similar tendency. If you see the PIGWA mutation or a PIGWA mutation, then they have a better response to the IST. But we not do routinely now.
Okay, thank you. Seishi, last question.
Thank you for a great talk. I'm very much interested in the appearance or positive selection of PIGWA mutated clone after CAR T cell therapy, right? So this is a commonly common in Abeles anemia and CAR T cell therapy. I assumed previously that this is selected by the T cell, autoreactive T cells. But in CAR T cell, it is impossible because CAR T cell directed to CD19. So probably the common pathogenesis phenomenon is cytokine storms. In a way, Abeles anemia and CAR T cell, both cytokine storms play a significant role. So my question is: do you think the mechanism of positive selection of a PNH mutated clone is something to do with cytokine storms? What is your thought?
Yeah, that's a great question. And actually, I'm very surprised to see the high prevalence of the PNH clone after the CD90 CAR T cells, because the hematopoietic stem cells does not express the CD19 usually. So, so we thought that the similar, maybe there should be some cytokine storm increased, then like IL-6 or some, I don't know which cytokine is important, but usually in the plasticemia, the interferon gamma or the TNF-alpha is important, but some cytokine status is not actually the similar between the plasticemia and the patient after CAR T cell therapy. So actually we don't have any answer which cytokine is important, but maybe cytokine storm is a common mechanism underlying the bone marrow failure.
So do you know any report that the positive selection 6q-UPD positive clone after CAR T cell therapy?
Actually, we are checking right now, but we don't see any patient with 6-PLOH after CAR T cell therapy. But we see some high prevalence of PNH clone after the CAR T cell therapy. So that may be 6-PLOH clone is escaping from the CTL attack, but maybe the PNH clone is escaping from the inhibitory cytokines. That's some difference.
Okay, thank you so much.
Okay, thank you very much. Again, thank you for this session, Uwe in Germany and Dr. Katame and the speaker now. So thank you very much.
Thank you.
Yeah.